Good afternoon. I'm Sharon with Nurse Tim, and I'd like to thank you for joining us for our webinar, Connecting the Concepts, Clinical and Classroom, featuring Karen Sherrill. We will have technical assistance available at 866-861-2896, option 3, or help at nursetim.com. Handouts are available to download for our live viewers in your login email and for archive viewers on the right side of your screen. Please note, handouts are for personal use only and are not to be distributed to others. On the Zoom toolbar, you'll find the Q&A pod usable by our live attendees. Our archive listeners are encouraged to drop us an email or give us a call. At the end of our webinar, we look forward to a discussion with your questions in the Q&A pod. We also value your input as to desired topics for future webinars. ANCC disclosures. Conflict of interest. This educational activities planners and the presenter have indicated they have no bias or conflict of interest. Successful completion. Criteria for judging successful completion of the webinar are attendance at the entire activity and submission of a completed evaluation tool. CE. This workshop has been awarded 1 contact hour by NurseTim Incorporated. NurseTim Inc. is accredited as a provider of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. For more information, contact help@nursetim.com. Objectives. 1. Identify 3 issues contributing to the need for connecting classroom and clinical concepts. 2. Discuss 3 strategies for connecting classroom and clinical concepts. 3. Apply experiential learning cycle framework toward connecting classroom and clinical concepts. Purpose. This webinar will encourage nurse educators to examine strategies that effectively link classroom concepts to clinical learning and vice versa, leading to higher level thinking and improved student outcomes. Throughout this activity, the speaker may use a variety of real and varied resources from health education vendors. They are for illustrative purposes and are not to endorse any product. All images and references to the NCSBN Next Generation NCLEX are the property of the National Council State Boards of Nursing and provided for teaching purposes only. And now I am so pleased to introduce our speaker. Karen Sherrill is an experienced nurse educator with over 20 years of teaching experience at Marcopia Community Colleges in Arizona. During her teaching tenure, she has been involved with multiple projects, including online education, informatics development, active teaching strategies, new grad transition to practice, and the integration of classroom, lab, and simulation technologies. She teaches 3rd trimester nursing students in the classroom and simulation lab, along with facilitating student success courses throughout the curriculum. Karen's full bio is available on the nursetim.com team page. We're so thrilled to have you with us today, Karen.
Thank you, Sharon, for that very nice introduction. Let me go ahead and take over control here. And hopefully we are in business. So welcome, everybody. First, I want to thank Sharon, but second of all, I want to thank each person who is attending. And whether you're listening to this webinar live or via archive, I realize how very, very precious time is. And I appreciate the time that you're taking to attend this session today. One of the things that I want to start out by saying is that I feel like this particular webinar is an opportunity for you to open your creative mind. I encourage you, as I put forth various examples today of ways in which we can be blending our clinical, our classroom, our lab, our simulation, think about some very creative ways in which you can be doing these same things within your own program. So the first thing I'd like to discuss is looking at trends in clinical education. And I think back to when I was in nursing school, which was like the dark ages, it was forever ago. And I think back to when I started teaching, which was in the mid-90s, and I think of how very, very different clinical education is now compared to what it was then. I can remember having the expectation of my 4th semester nursing students that they would be fully independent in the care of 4 patients during a 8-hour clinical shift by the end of their 4th semester rotation. And that was the expectation. And we could set those expectations because our students had far more clinical hours, but they also had far more independence in providing care for patients. It made a dramatic difference in their ability to be prepared for clinical practice when they exited the nursing program. So what is it that's impacting us today? Well, I'm not sure about your school, but I'm guessing it's a lot like my school. And we have fewer and fewer number of clinical sites available to our students. I'm in the Phoenix metropolitan area. There are lots and lots of clinical opportunities, but there are even far more nursing students in the metropolitan area, within the city and within the county. And the challenge that takes place is that although there are lots of clinical sites and lots of students, the problem is that bedside nurse who is just simply getting exhausted from teaching the students, teaching the new employee RNs, constantly precepting and proctoring and being put in that situation. It gets very frustrating and stressful for them. So that has led to a lot of our agencies cutting back on the amount of students that they're accepting. We also have found that we have to shave hours almost to a bare minimum in many cases because we don't have the adjunct faculty in order to oversee our students in the clinical setting. So we have made adjustments over the years of the amount of clinical hours that students are seeing. Once our students do get into the agency, what they're doing for our patients is different as well. Many facilities have limitations on their access to technology, in that they're not allowing students access to the medication dispensing machines. They're not allowing the instructor to have access. They're limiting which pages or parts of the electronic health record the student's able to see. And because of those limitations, again, our student is not getting a deep, rich environment. Many students, when I'll go to the units and I'll watch them up on the floors, rather than being the person leading the nurse into the patient's room to perform an assessment or to perform a procedure, they are in fact the ones following the nurse. So our students are not pre-selecting. They are simply taking direction from the experienced nurse that they're working with, and they're not providing independent care. They're waiting to be assigned tasks and duties and things that they can do to fill their time, and it's not allowing those students to think independently. Yet, on the flip side, we have the expectation from our agencies that our new grad is expected to be independent, competent, to be a great critical thinker, to be great with clinical judgment. Yet we know that that's not necessarily what our students are, what our schools are producing right now. And I would anticipate that many of you are feeling these same pains as you're watching your students in those clinical areas. So what are some of the biggest, greatest, astronomical changes that we have seen recently? And I know that you would probably choose these top two as well. First of all, we have Next Gen Clinical Judgment rolling our direction. We know that April 1 of 2023 is going to be the rollout of that exam style for NCLEX. And we know that that process of clinical judgment needs to be embedded not only into our clinical situations, but into our classroom, into our lab, into our simulation, so that we can have our students best prepared when they are going to be taking that exam in a short amount of time. We also have recently, through 2020, 2021, we are seeing some limitations of clinical sites as a result of COVID-19. Many of us have been shunted out of the hospitals, the acute care settings, and we've had to kind of make do with whatever clinical experiences we can find. This semester, I teach third semester. I've got students who are entering the hospital and touching patients for the first time in their nursing career because of the restrictions and limitations we've had with COVID. And it's very heartbreaking, I think, for most of us to see how are we trying to enrich and build those opportunities. While we've migrated to online learning, we're using a lot of virtual simulation. We are doing whatever we can possibly do to try to fill the holes, plug the holes, tie the pieces over, and continuing to use those processes, not only in clinical, but bringing those into all facets of the student's education is going to help them think at a higher level when they are in fact at the bedside. So let's look at the faculty culture, the pedagogy, and how we've really transformed from a traditional type of educational model. One that's very interactive and includes students as the primary learners. You know, I think back to the year 2000 when Patricia Benner introduced her information, her work that she did with the IOM, and how we were transforming nursing education. And it really looked at these two transitional models of how do we take that classroom that's no longer faculty-centered, turn that into a student-centered environment. She talked about taking teaching out of clinical and making your classrooms look like a clinical setting and not a PowerPoint lecture. Getting that focus off of teaching, putting that focus onto learning, making sure that students are continually reflecting about the connections they're making. They're being provided stimuli that really motivate their learning and help them to understand this deep level of learning. Keeping in mind that that was over 2 decades ago, and we still are challenged with this process. And it does not matter whether we are in a classroom or whether we're in an online format. It is so critically important that we shift the way in which we are teaching our students so that we can make sure our students are learning at a much higher level. This is consistent with the younger generation we're seeing in our classrooms. This is the type of learning model that students coming into the nursing programs are now going to be expecting, and it's so important that we're providing that to them. How do we change our focus? And to put that into a visual, how do we get rid of what we're seeing on the left and turn it into what we're seeing on to the right? We want to have our classroom look like a hospital setting. We want all of the information we provide to students to sound like actual patient care. Gone are the days where we need to be regurgitating the pathophysiology of a disease process to our students and to our classroom. That is information that students can get from other means and other modalities, and the amount of time that they have with us in the classroom really needs to be spent applying clinical situations. That's our expertise, and that's what we need to be sharing with our students. So how do we provide that? Well, one of the big key pieces to that is to make sure that we are integrating clinical judgment at every facet of their education. The transition to the term clinical judgment, of course, is a result of the clinical judgment measurement model that has been provided by National Council of State Boards of Nursing, recognizing that the transition to the next gen testing that is going to be coming forward is based upon our students understanding the clinical judgment model. So I would not be doing any service if I did not discuss the importance of clinical judgment when we're looking at teaching our students. If you are not familiar with clinical judgment measurement model that's being rolled out by a national council, I highly encourage you to, if you have the opportunity to watch some of the other NurseTim webinars, I encourage you to take advantage of many free sessions that are being provided by different publishing companies. I encourage you to visit National Council of State Boards of Nursing website, where there is a bunch of information and videos that talks about next generation NCLEX. That's a key piece of what we need to be integrating in everything we do with our students. This particular model demonstrates how critical it is that we have that clinical judgment piece in every aspect of learning, class, lab, simulation, clinical, and that those 4 areas need to look very similar to each other. There needs to be a correlation. They can no longer be on silos. That's what's going to create that competent new grad nurse that we so desperately are wanting to produce. So we're going to go through 5 different activities, and these are simply some activities that will help you to take the concepts and apply those at a higher level of thinking. Let me first start by giving a little bit of background and how it is that I use these types of activities in my classroom. Several years ago, I went to a flipped classroom model. So my students are expected to listen to my voiceover PowerPoint lectures before coming to class. I have them not only listen to my lectures, but I have them perform some pre-class activities so that when they come into class, they're prepared and ready to go. Classroom is spent applying the knowledge and not giving the knowledge. Now, certainly, I am going to clarify concepts, clarify ideas, clarify topics, but I don't reteach. If I was to start reteaching, there would be no reason for students to listen to the voiceovers. So it's very important that we reinforce the information, but we don't reteach the information. My very first section of the class is, okay, let me clarify what you heard on the voiceovers and what's unclear to you. And we spend 5 or 10 minutes just simply answering questions of the material that has been pre-recorded. Now, within that pre-recorded material, that's where they're going to get the pathophysiology, that's where they're going to get the disease processes, the nursing interventions, they're going to get the appropriate medications and diagnostic treatments, and they're going to get the list of the complications that can occur. It is simply knowledge level information. It is the nuts and bolts. It's a summary of what they'd be reading from their textbook. It just gives them the base knowledge. Now, what I want them to do when they come into class is I want them to be applying the information. And I have to say, if you look at the theory behind a flipped classroom, that's not completely what I do. A flipped classroom would mean that they listen to everything before they come to class. When they get to the classroom, they in fact work on things, and I guide them through these different activities. What I actually do in class is a better term that I like to use is the scrambled classroom. A scrambled classroom means that it's constantly changing with different activities. So I use a PowerPoint at the front of the class, and it basically is an agenda. It keeps me on track with the different activities that we're going to be going throughout that particular 2-hour session, 4-hour session, however long I happen to have in class that day. And each PowerPoint slide is going to give a different type of activity. So they are using, excuse me, they are using various steps of the clinical judgment measurement model. And then the next slide that we turn to, maybe they're looking at complications that can be, that the patient may have pertaining to medication from the different diseases they prepped on. And then the next activity may be something like this one, compare and contrast. So the intention is simply to have them continually thinking. One of my philosophies, and I tell students from the first day of class, this class is going to be very different than what you've had in the past because it has a very much a clinical focus. And the expectation is that you're going to think harder than I am. I want you to walk out of class today and your brain needs to hurt. And the reason for that is because if your brain doesn't hurt, then I have not done my job. I have not made you think deeply enough in order for you to get out of this class what you need to get out of it. Now, let me also share that any of these activities that I have in my classroom, the very next week, I can use these activities as a post-clinical conference. I can use these activities as a ticket in the door to lab. I can use these activities as a post-simulation debriefing activity. So know that an activity that is truly clinical based is transformative in all of those different learning areas. So by making some minor tweaks and changes, it's really easy to apply these activities in multiple locations. You could take this, you could post it to a discussion in your class. If you were in the virtual world, put that into an online discussion and have student groups lead those discussions. There's a million different platforms, and all of this is not about the activity, it is about the thinking that's taking place. So let me show you this first activity, compare and contrast. Students examined 4 patients with the same diagnosis, medications, treatment, culture, whatever comparison you want them to make. They might compare and contrast assessment findings, treatments, responses, complications, any of those things. So give students an instruction, and today in clinical, I want you to find 4 patients within this nursing unit today that are all on a beta blocker. And when you come to post-conference today, I want you to have some information pertaining what's the same and what's different about these 4 patients, but the fact that they're all on a beta blocker. Well, hopefully as the students are doing that comparison, they're going to see, well, you know what? This patient is on a beta blocker for this reason, but this one's on it for another reason. And having that higher level of thinking and understanding is really going to build their ability to apply clinical judgment. So here's an example that I could use in my classroom. I could provide 4 different scenarios of heart failure, and I could simply put those in my PowerPoint in the front of the class. Or I could break students into 4 groups, and I could have each group come up with their own short piece of information pertaining to a client that's experiencing heart failure. Now, with this comparison, I want students to think maybe independently or with a partner or in a small group, do a comparison of these 4 clients, all of which are in heart failure. Can you determine if one of these 4 patients is maybe in worse heart failure than another? Can you determine if one of these patients are at higher risk for other complications as a result of their heart failure? Can you determine which of these clients is the highest priority and which one the nurse should see first? Can you determine with these 4 clients which one can be delegated to an LPN? Which one would be appropriate to have the UAP ambulating to the bathroom and which one would not? So running students through these clinical-based scenarios with just snippets of information develops that high-level thinking that our students need. These do not take any time to put together. You can see there's just a minimal amount of information, but I want students to do a compare and contrast. What's good, what's not so good? What are you going to do about it, nurse? Because when we get into clinical settings, they're going to have patients in beds 1, 2, 3, 4 that are going to look just like this. And the student has to be able to prioritize these things. Now, if I'm in a clinical area, I can have my students, of course, go out and find 4 patients with heart failure and bring back to me what their lungs sound like, what's their pulse ox, how much oxygen are they on, and what medications are they taking, and have students retrieve this information. I can also take this information and I can take it into the lab. But today in the lab, we're talking about different modalities of oxygen delivery. I can use these 4 scenarios and have students determine, is this patient receiving adequate oxygen? Do I need to further assess? Do I need to request a higher level of oxygen be delivered? Are there other things I need to be doing for this patient to meet their oxygenation needs? So you can see how a simple activity such as this, there's a million different ways to take it. This one is fun too, and I think it's important for us to continually be embedding culture and religion into our classes, lab, simulation, clinical, knowing that culture and spirituality is one of the embedded themes in the NCLEX exam. So students are going to need to be versed in these discussions and topics and prioritizations and how to best meet these clients' needs. So again, I've got 4 very unique and different cultural and or religious and or dietary impacted differences. I want my students to do a compare and contrast. Okay, how are they going to care for each of these 4 clients differently? Is there anything they see here as a cue? Knowing that clinical judgment measurement model is looking at recognizing cues. Does my student see any cues here in each of these 4 clients? And having those discussions with a peer, having those discussions within a group, in a clinical group, in a post-conference group, in a sim debriefing group, and you're all of the above. Medications, if you're the pharmacology instructor, I think technically we're all pharmacology instructors, but there are some proud pharmacology instructors out there. Not my favorite topic, that's the reason why I say that. But a great way to educate about medications, again, it's not about memorizing a therapeutic DIG level. It's about looking at that DIG in relationship to other pieces of information that provides that student with a higher level of learning and understanding, an application of how to care and make clinical judgment decisions for that patient that's in their best safe interest. So what I'd like you to do now is, if you are listening live, I would like you to pause and reflect for a second and type into the Q&A an idea or a suggestion of a way in which you could use this in your classroom. So think of some material that you have within your own classroom that you could put into this compare and contrast format and use as soon as you go into class, lab, sim, clinical, even tomorrow. If you're listening by archive, I want you to hold on. I'm going to share some of these suggestions and ideas with you. But take a second to think about it. Chat is disabled. That is correct. Q&A is how you want to answer your responses for those that are listening live. Okay, so I'll give you a second to think about that. Let's say that you are a mental health instructor. Okay, what are some things that you could teach that could be utilizing a compare and contrast? What if you're a fundamentals instructor? What are some suggestions or ideas of a compare and contrast? So great, we have someone making a recommendation comparing delirium with dementia. Absolutely. That could work in fundamentals. In some schools, that would be in your mental health curriculum, but that would be a great way for students to really learn at a deeper level these different conditions and situations. Oxygenation, perfect. Just like the example we gave with the O2, and granted, that was some oxygenation with heart failure, but you could even put that into a fundamentals level by just looking at different types of oxygen delivery systems, or determining when it is that that patient needs to be placed on oxygen. What determines that they're at that level of care that I need to get an order for oxygen? Crohn's colitis. Great comparison. I could see many of the ulcerative conditions. So you could certainly do the ulcerative colitis, the Crohn's disease. You could do a comparison with that in maybe a diverticulitis or an appendicitis or some other lower intestinal GI disorder that have a lot of similarities, but certainly students need to be recognizing those differences. Someone had mentioned that they recently did a death and dying sim, or he's going to be doing one next week, and did a compare and contrast for cultural religious considerations. I love that idea. That is absolute brilliance. That's a great way to interject that into the curriculum. And again, don't just use it a single time within that nursing program. Make sure you're sprinkling that throughout the entire program. So lots of great ideas coming into our question and answer session. So our second activity, I like to call this one Labs Without a Name. And I actually started this one years and years ago when I was just clinical instruction. I was not full-time residential at the college yet. And I gave students what I called a mystery lab report. And the mystery lab report is simply the data. It is not the diagnosis. It does not provide the details. You know, when we teach labs and abnormal labs to our students, a lot of times we'll say, oh, your patient's in with acute renal failure, and then we'll proceed to give them a creatinine and a BUN level and a potassium, and we give them the answers by doing that. That's teaching them the knowledge. But what's more important, can they take that information and help to determine what's going on for the patient? So what I'm going to do is give my students a list of mystery labs, and as I start them in the program, I'll probably give a single day's lab report or a single time lab report. But what I want to do as that student progresses in the program is I want to give them lab trends. Lab trends is what they're going to be seeing on Next Gen NCLEX. They have to be able to interpret that information. When I give them a trend of lab, I am not going to give them a diagnosis. I may or may not give them a patient's age. I may or may not give them a patient's gender. I'm not going to give them those details, but I want them to simply look at the numbers, see if they can interpret what is going on. Then your students look at that and say, oh my gosh, this patient could be in diabetic ketoacidosis because look, their glucose level is very high, their potassium level is very high, and you know they've got they're in a metabolic acidosis on their ABG. Can they take that information and then after they've made that conclusion, ask the question, what's your priority assessment? Okay, What are you going to do walking into that patient's room? Because we don't have a diagnosis on that patient yet. They just came into the emergency room with confusion, tachypnea, or Kussmaul respiration, but I don't want to tell them that because, again, it gives them the answer. They've got a rapid respiratory rate, their blood pressure is low, they're tachycardic, they've had polyuria. I'm going to give them some assessment information with a lab report and see if they can put those parts and pieces together. I want students to now take that long list of labs, and I want them to pick out my number one concern. Which of those labs is the highest priority? Now, if I'm looking at that DKA patient, students are going to say, oh my gosh, look at it, it's that pH that's so concerning. And then we might say, you know what, is anybody worried about this potassium of 6.8? Is there any additional assessments we should be making as a result of that hyperkalemia? Lead them down that path of making those sound clinical judgment decisions. We can take this mystery lab report, I can bring it into my classroom, provide it to my class as an activity. I can do that electronically as well. I can show it on the screen, have open discussions if I'm in Zoom or Google Meets or whatever my platform is. I can use this as a post-conference. I want every student today to come to post-conference with a mystery lab report so that we can have the discussion. I can use this in simulation. I can provide my students preparation for their simulation day by giving them a mystery lab report. They don't know who the patient is they're taking care of in SIM. They haven't got a report on that patient yet, but they've got a mystery lab to start with. Can students put the pieces together to think about how to care for that patient as they're walking into the SIM room? I'm going to also provide a mystery lab report before my students go into the lab that day for their NG practice. Okay, what if I've got a mystery lab and I've got some patient with electrolyte imbalance, and now I have an order to place an NG tube? Well, teaching the skill of an NG tube is one thing, but thinking about what's happening with that patient before I place that NG tube is even more important. So this is a great activity that students absolutely love, and they totally get into it. It's like a big mystery solving what's going on. So here's an example of what it could look like, and you just simply sprinkle normals and abnormals. I don't know anything about this patient. I have not introduced this along with a case study. I'm simply giving them the numbers to see if they can build a story. Can they figure out the correlations and the trends and data that they're seeing on this lab result so that they can best provide a high level of clinical judgment in caring for the patient. Now, if you don't have the time or the ability to create these on your own, consider going to whatever you're using for your electronic record. If you're using maybe an Elsevier product for your EHR, if you're using a Lippincott product for your EHR, whatever you're using, go into some of those sample patients and simply do a screenshot of these lab trends or build your own patient within that. Have students take a look at that information directly in their EHR and have them make some decisions about what's going on without knowing anything about the patient. Tag tying on that, very similar. How about a sample radiology report? And this example that's here, I like it just because it is vague. If you look at the possible diagnosis, and this one does have patient information on it, doesn't tell us what's going on with this 16-year-old, but it does say that there's right lower lobe pneumonia, most likely caused, but cannot rule out metastatic cancer, fluid accumulation, consolidation, could be empyema, hemothorax, pleurisy, lots of possibilities here. So then we can sit in our class or post-clinical or whatever and have discussions about the what-if game. Okay, what assessments would I see if this was right lower lobe pneumonia? What assessments or history information would I need if this was metastatic cancer? What information would I anticipate if it's an empyema or a hemothorax or a pleurisy? And lead students down the road of taking this information and applying it to care of the patient. Once again, this works beautifully in clinical. You can have students retrieve this information directly from the electronic record of patients that they're caring for. So once again, let's go to the Q&A, and here if you have some suggestions on how you could use the mystery lab activity. whether that be in lab, sim. How could you use it with your curriculum? Now, one of the questions that often comes up is, how do I apply this in fundamentals? Because many times students in fundamentals don't have a lot of foundational knowledge to be able to put these parts and pieces together. But think of other trends of mysteries you can provide to them. So maybe provide a mystery trend of an intake and output record, okay? Looking at maybe a patient who has a urinary catheter or someone who has some early signs of renal disease and has a decrease in their urine output. Can students put those parts and pieces together? One of the recommendations from one of our attendees is saying a mystery trend of GI bleeding. Wouldn't that be great fun? I would even suggest taking that mystery trend of GI bleeding, taking it pre-bleed, taking it maybe post-transfusion or post-endoscopy, where this patient with a GI bleed has gone and had a diagnostic procedure and now their numbers are increasing. And depending on the level of your students, this could even be effective where maybe you have your patient in the lab trends show up with a hemolytic reaction to the blood that they received for this GI bleed. And if PAC cells is a part of your GI bleed content, which it is in my curriculum, I can have students see if they can recognize just through a lab report a patient that has had a hemolytic reaction as a result of the blood transfusion that they received for the GI bleed. So make your mystery lab trends go over 3, 4, 5 days and watch this trend of information. See if students can put the parts and pieces together. You'll be amazed at how well they can do with this. And of course, it requires some guidance, but sometimes you just tickle them with a little bit of teaser. It's like, has anybody considered this? And then all of a sudden the light bulbs go on. It's a great, great fun activity. So activity number 3, this one I like to call find an error. And there's no doubt that we learn best from our mistakes. And I think also very impactful for students is when they see mistakes or errors or poor choices that take place in the healthcare institution. I know many of our students, and I'm in a community college, they come in and I think they have kind of a Pollyanna idea that they personally will never make a patient error. And they're very shocked when they learn that, yes, errors in fact do occur in healthcare. So rather than being afraid of this or even giving students the assumption that they'll never make an error, what is it more importantly we need to teach them is how do we identify errors and what do we do about it? If we want them to be safe practitioners that are initiating change so that those errors never occur again, let's make them really good finders of those errors. It's no different than a clinical judgment measurement model is recognize cues. Well, errors are cues. There's no doubt about it. So as a clinical assignment, your students can have the need or have the desire or have the assignment to find an error today. Maybe it's something that actually happened, or maybe it's something that could have happened. So for example, have they found anything related to a medication error, whether it's something that's mislabeled, is it something that was misordered, is it on the wrong EHR, whatever the case is. Maybe there was an error given in a handoff report where there was certain information that was shared that was not factual to the case or the patient situation. Maybe a communication error where somebody thought they had requested something, but that communication never took place. Maybe it's a documentation error where somebody opened up the wrong EHR and started to document information on the wrong patient. Whatever it is those students can find, have them bring that information to post-conference or have them bring those examples back to you in class. So what will I do? I am going to now take the errors that my students have found in clinical last week, and I'm going to randomly select 3 students or 3 students' examples of errors that they saw. And we're now going to go into a small work group, and we're going to create a fishbone diagram to see if we can, in fact, improve patient outcome as a result of recognizing that error. And if you're not familiar with fishbone diagrams, there are tons of YouTube videos, different things that are great learning for your students. But this is really the process of making quality improvement changes in healthcare. And this is something students need to be familiar with because they're going to be experiencing it once they get out there. Consider how impressed that a potential employee would be if during the interview process, the student managed to squeeze in their information about, one of the most effective things that I did during my clinical rotation was we were able to find some near-miss errors in clinical, and then we worked them through a fishbone diagram to come up with a plan that improved patient outcomes. Imagine how effective that would be for a student to share that in an interview for someone who's a potential hire. So these are great skills because they transfer beautifully into current day practice. And they give your student the understanding is that, yeah, we try to find errors because then we can improve upon it so that it's not going to cause patient harm. So again, let me have you open your Q&A. Think about pause and reflect. There is a comment here that's asking what is done after the error. Absolutely. So not only what is the error, but what was done about it. Very important for our students to learn that process. What does it tell you about yourself? And accountability. We desperately need accountability in our culture right now. So I think it's important for us to continually reinforce the importance of being accountable, especially in nursing profession. Excellent comments. I appreciate your input. So our fourth activity is what I call the clinical card. And it can be called a cue card. It can be called a curveball. I've heard references to many different things over the years. But I think this is a great activity in that it stimulates thinking on the fly. It allows our students to go to a deeper level of understanding very quickly. So what is it that I'm going to be using this clinical card for? I can use it, like I said, in clinical lab class simulation at any time a student knows that they may get carded. During my semester, students are fully aware. I let them know right off the bat, this is one of the learning strategies I use, is you may get carded. And what this means is that at any point in time, I can go ahead and walk up to you, hand you a clinical card, and you need to stop what you're doing and rethink your patient situation based upon the information I just gave to you. If you're using this with students, encourage them to think independently first. Then use a think pair share. So they think independently first, then they're going to talk to a classmate about the answer, then they're going to discuss their answer at post-conference. So when are these most effective? When I'm in clinical and I walk onto a nursing unit and I have students that are not actively engaged in patient care, I'm concerned. Because if they're there for a 12-hour shift, I want 12 hours of focused learning taking place. So if the unit is not active enough to keep my students engaged, they're going to get a clinical curveball card. They're going to get a card that will tell them what they need to be doing differently or what they need to be thinking more deeply about. When my students are in lab and they're practicing XYZ skill, maybe it's Foley insertion, maybe it's IV push medication, we all know that when they are in person, their conversation goes from learning the skill to talking about what they have planned to do Friday night. And when I hear those conversations come up, that student and that pair of students is going to get a curveball. So whatever skill they're currently performing, I'm going to give them patient data that will change how they're performing that skill so they now think clinically about a skill they're performing. Let me show you some examples. So this one has to do with drains and tubes, and a healthcare provider calls and says to prepare for the insertion of a chest tube placement at the bedside. Okay, so my students that are on the nursing unit that are sitting around twiddling their thumbs because their patients are off the unit for a procedure, one went to dialysis, the other one's sleeping, so I don't want to wake them up. Say, guess what? The provider just called and says we're putting in a chest tube. I want you to go back to the central supply area of the unit, and I want you to make a list of everything you would need to pull very quickly in order to assist with this procedure. Go. Okay. And that will give your students some things that will have them focus in on clinical judgment. Now, the first thing they're going to think is, oh my gosh, I don't know what they need. I don't know what we need for a chest tube placement at the bedside. And then my response is, I encourage you to find a policy and procedure on that and use that as your guide in order to prepare for this. And oftentimes that will give students the guidance that they need in order to get started on this particular task. Send them to the policy and procedure manual. I might give students a scenario where your postpartum client goes into the restroom, passes a large clot size of an orange, and feels lightheaded. What are you going to do? Again, I want them to break that down into tiny little details. Okay, what will you do first, second, third? Make sure they prioritize first, second, third. Okay, so well, if my patient's lightheaded, the first thing I need to do is sit them down because it's a safety risk. Excellent. Good thinking. That's perfect. Now, what would you like to do? Well, you know, I'm a little worried about the patient's blood pressure, so I would go ahead and lower the head of the bed. I check the blood pressure, whatever, place oxygen, whatever you feel would be most appropriate. But for my patients or my students that are on this postpartum unit and they're sitting around just waiting for the contractions, hand them a scenario. Give them situations that could occur at the point of care where they would have to get up and they would have to act now and do something. Now, these clinical cards, certainly you can create your own. You can make them onto sticky notes. You can write them up as you think of them. These particular ones actually are available through Nurse Tim. You can also have students create their own. Okay, and we know that create is that highest level of Bloom's taxonomy. So think about having students create their own curveball cards. They could do those in a pre-conference for the day. What are the top 3 things that could happen to your patient? Okay, give me a scenario. Create a curveball for me. What would that look like if that was going to happen during your shift today? That helps them to anticipate changes that might occur. Activities, not only do we have those curveballs, but I've got a really slow unit today. I want students, I'm going to ask you to compare and contrast 5 clients at risk for bleeding from diseases, labs, or medications. They bring that information to post-conference. I might have a patient with hemophilia. I might have a lab that has a prolonged PT-PTT, and I might have a patient who's on Plavix, okay? But now let's do a compare and contrast, okay? This is very conceptual. Risk for bleeding is not illness specific, but how do I care for a patient who's at risk for bleeding regardless of what the cause is? I can have students observe 5 examples of professional behavior among healthcare workers. That's their assignment when they go into clinical for the day. Now what I want you to do is not bring that to my post-conference. I want you to bring that to class next week because we're talking about communication of healthcare workers. We're talking about role and scope of practice. And those 5 examples need to be brought to class next week because we're going to continue these discussions in the classroom and apply some activities and practice some interprofessional communication that might be more advantageous than the ones that we saw. So again, pause and reflect. What are some ways we can use cue cards, clinical cards, curveballs, whatever you want to call them? Think about some ways, and this time rather than typing it into the Q&A, I'm just going to give you a minute to think about it and jot it down on a piece of paper. How could you use clinical cards in your teaching? And I'll be quiet for a minute to let you think about that. So for those that are quick thinkers, share one of your ideas in the Q&A. We must have slow thinkers today. No, great ideas are coming through, but I'll tell you, my favorite way to use this is in lab. I have found that learning a skill, we teach skills to our students by rote memorization. They follow a step-by-step recipe card. And using clinical judgment cards such as this in the skill lab setting puts a whole different layer onto what they're learning because it certainly gives it context. And again, National Council Clinical Judgment Model talks about context. This is a perfect way in which to make that happen. So the last example that we've got today is, there we go, what I call a 5-question assessment. And what I do with this is I give students a 5-question, quote unquote, test at the beginning, middle, or end of the day. And these questions, they could be a variety. There's times if I give it right at the beginning of class, sometimes I'll give a very knowledge level 5-question assessment based upon the information they had to prepare before they came. If they are in the middle of lab or middle of simulation day, we may have 5-question high-level alternative format questions that I give to students. Or it might be the next-gen style item. You can do these 5-question assessments at any time. I don't count them for points. I have at one time, but I don't anymore. But I do let students know that these 5-question assessments are usually very reflective of how they perform on a test. So I encourage them to take them very seriously. I also will write down, I'll have them turn them in just enough for me to write down what their score is, because it helps me to identify my low-performing and my high-performing students on a formative basis rather than waiting till exam day to determine who's not getting it. So these 5-question assessments can be placed in a multitude of areas. Again, it just gives you a formative way in which to evaluate students and come up with some ways to improve their exam process and so that they know that they're studying more deeply. Well, I keep flipping a couple slides here, sorry about that. So the other thing too, use these as a high-level item with or without answers. So you can have a situation such as this, nurse is caring for a client who puts on a call light, returned from a procedure, heart feels like it's skipping a beat, what action should the nurse take? Now this sounds like a high-level application test item, and in fact it is, except I'm not going to give my students the answers. We use this as a class activity and students need to shout out what the answer might be. So I'm going to gather from this a whole variety of potential answer options, and it gives me the ability to actually write a test question by getting feedback from my student and my class to determine if they can put these prioritization processes in place. So we could do this as a class, we could do this as a written activity. Something like this could be a part of your 5-question assessment and make it a fill in the blank. Do students understand the information? Can they apply it or not? I could also use an alternative format, and this would be a priority order. So my students are offered 5 different patient scenarios, and they need to place these clients in the priority in which the nurse should provide care. So again, high-level thinking. Individual students might be challenged for this, but this type of 5-question assessment would be great maybe for them to work in pairs or small groups. Or they can start out and do it independently and then put them into the group and have them discuss their answers. So again, great way in which to get to high-level thinking. Next gen items, of course, again, same thing. These work beautifully in a 5-question assessment. And we know that those next gen items have lots of electronic record parts and pieces, and the student really has to have a high level of understanding clinical judgment in order to best answer those questions. So pause and reflect. I just wanted to make one comment that came up in the Q&A, and one attendee had suggested the ultimate curveball where both men appear in the labor support saying they are the father of the baby. Boy, isn't that the truth? That would be a really bad nursing day. Great comment. So how do we link all this together? First of all, we want all these parts and pieces to look the same. clinical class, lab, sim, all of it needs to link together, needs to have clinical judgment throughout, but more importantly, how do we determine how to link it together? We have to tie it to the test as well. So tying it to your 5-question assessment, tying these scenarios and placing them into test questions is very much fair testing because they're activities we had in class. Now I'm migrating that to a test question, and that's fair testing for my students. So think about ways that you can link all of these pieces and parts together. So we've got about 5 minutes left, and I would love for you to put any questions you have into the Q&A, and I will do my best to try to answer those for you. If you're listening via archive, I encourage you to send me an email. You can send it either to help@nursesync.com. You can send it directly to ksherrill@nursetim.com. Either way, I'm more than happy to answer any questions that you have electronically, but for those that are live in the attendance, please go ahead and type in your questions. And while we're waiting for those to come in, there is one question that I do have here. It says, what to do with level 1 clinical students in long-term care facilities? Students do not give medicines, cannot do procedures, have never touched a patient. So the secret is, I would say in that situation, is to get students comfortable with communication skills, get them comfortable with introducing themselves to patients, have some compare and contrast of communication activities would be really good because it would provide those students with gaining that comfort level. Certainly in a long-term care facility, you could have the find the error activity. Are there breakdowns of communication? Many times communication in long-term care is very different than communication in acute care. But can students start to recognize and identify different ways in which communication is taking place? Is it therapeutic communication? Is it effective professional communication? What are some discussions we can have about that? You could give the students curveball cards where they have to go in room to room, and maybe they have to do an assessment of heart sounds on 5 patients. So they'll have to go into their client's room, they'll have to introduce themselves, explain their nursing students, and say that part of their assignment for the day is to listen to heart and lung sounds and ask permission to be able to do that. And so by comparing heart and lung sounds, your student is going to improve their assessment skills because they're hearing more abnormal findings. You know, many times they have learned heart and lung sounds in the lab on each other, which most of the time is normal. But if you can put them into a long-term care facility, I guarantee that they're going to hear lots of abnormalities. So having some of those foundational assessments is a great way to do a compare and contrast activity with them, those students. Are there any more questions from anybody that's listening live? And if not, I will go ahead and turn this back over to Sharon. She'll tell you how to complete your evaluation to get your continuing education certificate. Thanks so much, everybody, for tuning in today.
Thank you very much, Karen. And now we'd like to invite our attendees to fill out an evaluation for CE and also include your valued feedback. For our live viewers, a new screen will appear in just a moment. Please click that Continue button to proceed to the short survey evaluation that will produce your CE certificate. And for our archive viewers, please click the evaluation link on the right side of your screen. Thank you, everyone, for joining us today.